Dr. Trin Chevron and Dr. Guillermo Ramos, your perspectives. We'll start with Dr. Guillermo Ramos this time.
So I think that was a terrific kind of response, and I can't agree more. I'm really happy that we started off with really questioning what we mean by vaccine hesitancy. I've also been very perplexed by the word. I think the focus should really be on our systems of care and our systems of prevention, and how trustworthy are those systems, and do they actually reach the people who are most in need? If we sort of flip it around and we think about whether or not we're doing a good enough job at being able to deliver services to people who need them and where they need them, how they need them. And then we have really predictable relationships that are based on sort of reciprocal benefits and sort of honesty and clarity. I think, what you'll find is that people make choices that are in their best interest when they understand those choices and when they have access and they trust that the information they're getting makes sense. In Mod Haven, again, the community that is very high in terms of number of diagnoses, hospitalizations, and deaths. I think in our project, we're currently doing a RADICS-UP randomized clinical trial where we're trying to increase testing and mitigation strategies. Some of what we've been hearing is that, exactly what Bengo was saying, that there's some basic questions about how trustworthy is the vaccine. Well, can they access it? But even when they access it, can they trust it? And then also really wanting services to come to them. If the idea is that they need to travel far, they need to sort of do many things like get online and continuously try to reload their computer to get an appointment to get vaccinated, it becomes challenging, and it creates sort of difficulties in folks being able to advance their health and well-being. We got to make it easy. We got to make it so that people can actually benefit. And, I certainly feel that sort of the future of how we're going to sort of effectively scale up prevention and mitigation is really through meaningful community engagement. We got to get out of our structures and move into the community and deliver healthcare to where people are.
Dr. Trin Chevron.
Thank you. So I learned a lot about vaccine hesitancy from my colleague Aisha Langford, and really understanding that there's a whole continuum about what it means to be hesitant regarding vaccines. And she also shared very good news that acceptability has increased from September of 2020 to December of 2020, and in the sense that in September, 1 in 3 people were more acceptable about the idea of taking a vaccine, compared to December, where it was about 2 out of 3 people. And that was across different racial and ethnic groups as well. What we're seeing on the ground is that from our community partners, that more and more communities in low-income areas have higher acceptability. And I just want to really echo what Vincent and Benga have indicated and have noted already, that the issues that are really underlying what's going on in terms of vaccine disparities really is rooted in access. So vaccine acceptability is not synonymous to vaccine access. And we're hearing that the greater obstacles are related to misinformation, knowing who's eligible, when you're eligible, how to navigate online sites, being able to secure appointments, being able to navigate language barriers, seeing that the need to have trusted messengers, trusted people from the communities, of having services provided in their own communities, in their neighborhoods is very key. But from my understanding too, of working with providers who are federally qualified health centers, they're seeing that a lot of the slots are being taken by people who are not residents of those communities. And so there are certainly barriers in terms of being able to access at the local level, and thinking through what are the ways that we really kind of circumvent those issues, where you don't need to have steady internet access, where you don't need to have a laptop, where you can, do things like some of our partners did census door-to-door outreach, for example, to really, make sure that every voice was counted. And maybe we need to think through, do we develop vaccine vouchers so that every resident in that community is ensured some access when they're ready? And so there's just like a number of things that we have to think through about access and reducing those disparities. the vaccine hesitancy still remains a challenge, and there will need to think about segmented, targeted approaches and to address each of those concerns. But really, with thinking through that, there's going to be increased resources for staffing, increased resources with respect to vaccine supplies. We also need to think through how do we ensure that there's vaccine equity.
We're going to stick with you, Dr. Trin-Chevron. We focus so little on the Asian American and Asian immigrant population, given the violent racism and known COVID disparities. What do you think we should know and what needs to be done?
Thank you for raising that issue. It's from a community perspective. It's been devastating to witness and experience the psychological trauma of xenophobia, of racist attacks towards Asian Americans at an individual level and at a community level. We know that this has been part politically motivated with the coining of the Chinese virus, the Kung flu, and all these other issues that have really, historically been an issue for many Asian American communities in terms of going back to the yellow peril and now with COVID. We know that nationally, more than 2,500 reports of anti-Asian hate incidents were reported last year between March and September. And that we also know that most of those incidents are underreported. And so that is an underestimate of what's going on in terms of anti-Asian attacks. The New York City Police Department reported an 8-fold increase in hate crimes towards Asian Americans in 2020 compared to the prior year. And so we also know that that must have implications on delayed healthcare seeking, delayed testing, of really trying to avoid the stigma of having a disease that many, mainstream media and the president, our former president, had announced as the community that brought the disease to the United States and to others. And so, that has been very devastating to many Asian Americans. But at the same time, I'm pleased to see that, on January 26th, President Biden signed a memo that really disavowed discrimination and condemning racism and intolerance towards Asian Americans, and really calling for a number of practices to reduce intolerance, to improve language access, and to be really explicit around denouncing racism as it is and how it occurs in terms of the physical and the verbal violence. What we can do in terms of addressing that, the media has played a very important role in terms of raising attention, but I think we as faculty, as part of academia, as part of the healthcare, working with our communities, we need to also be explicit in denouncing all forms of systemic racism and all forms of stigma as such.
Thank you, Dr. Guillermo-Ramos or Dr. Ogadegbe. Any additional comments?
I think I will just say, I really loved what Chao articulated. I thought it was quite beautiful. Chao was really impactful. I will maybe just try to extend the focus beyond the Asian community, but obviously be inclusive of the Asian community. I think there's a pervasive pattern in our country of this sort of societal sentiment that is targeting groups. And I think there have been a number of big events that have really been transformative that have sort of erupted in recent years that reflect long-term sort of enduring systems of racism and oppression. And so obviously Black Lives Matter. And then prior to Latinos being deemed essential workers, once a coronavirus hit in March of 2020, if you think about what was happening with the wall and sort of the anti-immigrant sentiment and sort of go back home, you don't belong here, and all of the increases in sort of anti-Latino sentiment. I think across each of the groups, what you see is the same basic tactic, the same sort of impact, and the same sort of negative consequence. The good news is that I think it's sort of more readily identifiable. I think there's more openness in our country to sort of see it, to recognize it. The bad news is that there are also people that feel more comfortable sort of taking that stance. And so I think we are at a critical point. I agree with Chao. I'm happy to see that President Biden did sign an executive order that was really focused on racial justice and undoing some of what had happened in the previous administration.
Yeah, I just have to agree. I think Charles raised this very well, and much earlier, actually, the racist attacks were happening in the subways. So it wasn't like this happened just a few months ago. It's almost a year ago, but thankfully it's been addressed now. The key issue, though, I think, is sustained effort on drumming that message. Because I think people are quick to forget, and we tend to want to blame the individual rather than thinking about the systematic approach to this. So I cannot concur anymore with my colleagues.
Thank you. Let's shift gears to mortality. Mortality rates are equivalent when patients make it to the hospital, if patients make it to a hospital with adequate resources. How does this contribute to health disparities in your particular populations of interest? And Dr. Guillermo Ramos, we'll start with you.
Sure. So I actually think Benga did a great job at sort of talking about this a little while ago about hospitals and sort of the idea that if you make it to the hospital, and assuming that hospital is adequately staffed and resourced, they're not overburdened, then people tend to do fairly well and there are sort of comparable outcomes. But I think the truth is that depending upon where you live and what zip code you live in, then that looks really different. And so I want to start maybe by just illustrating a bit about exposure. And I'm going to highlight things that maybe others haven't said, and I'm sure others will sort of amplify. So one of the things that's been really interesting to me is that a lot of the guidelines that we have, whether you look at sort of the CDC or you look at New York City, New York State guidelines, there are some basic assumptions about prevention and mitigation that really don't reflect the communities that I'm working in. So a lot of what I'm seeing are transmission rates that are quite high in households and in settings like public housing and intergenerational sort of Latino families where you have people of all different ages living in high dense environments where they're taking public transportation, where they may be underinsured or not have insurance, where they may not have a routine, steady point of care, where they may not have the option of being online and being able to work, where missing a day of work means missing income, and that's not possible. I think, linguistic barriers and things not being available in Spanish. I also think that the anti-immigrant sentiment, and even if you are in fact an American citizen or a legal resident, you may be part of a household where somebody is undocumented and there may be hesitancy or maybe fear about sort of presenting. Certainly if you think about areas like El Paso and the border area, which has been very sort of hard hit in terms of COVID, lots of fears about INS and Border Patrol and what that means in terms of presenting in our systems of care and will they be detained. I also think that, sort of limited consideration of transnational families. If you think about an area like the border, which for many of us that live in New York, it may seem like an unfamiliar space, but for people that live there, prior to COVID, there was daily crossing, and really the border was not the same as the way we might envision it. It's really a place that's sort of a border space where people move back and forth for work, for family connections, for ties in terms of living on both sides in Mexico and in the US. And I just think all of those things play out and shape who gets exposed, who becomes a case, whether or not you show up to the hospital or clinic, and if you do show up, where you show up. And depending upon where you show up, as Benga said, it will determine your outcome.
Thank you, Dr. Ogadegbe.
I think Vincent said it well. We know if you make it in, data has showed, regardless it's about COVID alone, chronic disease too, the disparities in care is largely driven between hospitals, not within hospital. So, and if you then take that further, the disparities has to do more with the quality of the hospital that's providing that care. But systematic review out there did make clear that in the hospital, we're looking at what they call case fatality. So the denominator is those who are infected. Outside of the hospital, that's mortality. And there, a whole host of factors that Vincent talked about. But the key issue here is your zip code. Your zip code predicts, unfortunately, your life expectancy. So the question becomes, what is the quality of the healthcare system in the zip codes we're talking about. The Black and brown communities live, low-income populations, pretty bad. And that's why we saw all of these things unraveled over the summer.
Dr. Trin-Chevron, anything to add?
Vincent Vegas, responded so well. I think the only other thing that I would want to add is that the other piece about reducing disparities in treatment is really understanding what treatment strategies work for different communities, and understanding, what might work well for South Asian populations versus Chinese American or other East Asian populations. Understanding what were the challenges. Was it really delayed access to care, or is there something in that treatment strategy that did not work for that individual and for that community in a sense? And so, one of the things that we've been trying to think through is how do we engage racial and ethnic minorities into a number of the trials that are being done now, with across the country in terms of therapeutic prevention and vaccination on COVID. It's really understanding how do we engage individuals across different communities to really participate so that we can answer that question. But I do want to go back to what Vincent noted, and I think the most significant thing is really preventing tackling structural determinants. There is certainly differential capacity to shelter in place safely. When you are living in a very low income, densely populated area, many of low-income Asian Americans who are living in ethnic enclaves, they're doubling or tripling occupancy. It's just hugely different to be able to think about sheltering in place, to quarantine safely, and beyond even just the issues of understanding access to testing and access to care. And again, I also want to reiterate the language barriers play a huge factor. In terms of, there are high rates of limited English proficiency, and which means that, being able to understand or to interact on a day-to-day basis in this country, and let alone to be able to understand all that goes involved in terms of COVID testing and prevention, as well as vaccination. So there's a whole host of social determinants that we also need to think through before we get to the issue of hospitalization. That's the only other piece I would, want to mention.
Thank you. Dr. Ogadegbe, this is a multi-layered question. We're having this conversation as if disparities are new. What would you say are your perspectives on where we are today? Have things changed? And based on the work that you've been doing and are doing, are we making progress?
Wow, that's a loaded question, truly. Have things changed? Well, let me start from the beginning. There's nothing new, frankly. For those of us in the field, there's nothing new. We've seen this before. We see it all the time. And in all the decades I've been in, both in practice and doing my research, I've seen this all the time. So here's what I said. We had a town hall when the former president became president about 4 years ago. And the town hall at the time, if you recollect, the mantra was that, Hispanic Americans are murderers, they're rapists, and all of that. I'm not going to repeat it anymore. And there was a whole heightened attention to the issues of racism. And I said something which is interesting, that nothing has changed. This is not new. What was new was a new government, but the issues hadn't changed. We've heard those sentiments before, but it was just now on the bigger pulpit, if you may. But I did say something else. I said, if anything, the next 4 years, the silver lining will be that this issue of racism is going to come to the forefront. I did not expect that it would be this bad because of the pandemic. So we had two viruses, as people would say: COVID pandemic, COVID-19 virus, and racism. And to have both of them at the same time, at a time when everybody is sheltered at home, watching TV and the news media, I think was powerful. And then you have we had Black Lives Matter before, but it became even more prominent around this time. So I think what changed was that platform that had those two events at the same time. The thing I draw people's attention to is that racism, structural inequities happens in all systems: healthcare system, criminal justice, child welfare, educational system. In this case, we have two systems in place: police brutality with intentional killings of Black men, and we had the COVID pandemic where it unraveled for a sudden, all of a sudden, the whole idea of the chronic neglect of Black and Brown communities. I think that's what Kamara Jones would say. When you have those two together, two different systems, the same underlying issue, but the same consequence as well: more deaths, more illness. So I don't think anything has changed. The only thing that has changed, maybe two things, maybe one and a half. One is the vaccines are here. So the vaccines are here now. So there's some hope at the end of the tunnel. We'll see, but we're hoping that they're here now. There's been a sharp drop, right, in the rates of cases and infection. There are variants, but I think we're moving the ball in the right direction. The second thing that has changed is the government. And that's also another major hope, because when the government changes, hopefully, we'd like to see some changes in the policies as well.
Thank you. Dr. Chevron.
I would agree with Benga's statement. I thought, COVID-19 really magnified the social and health inequities that have been occurring in the United States for decades. What happened last year, with all of us being home, being able to witness, very vividly what was going on in terms of the police brutality and the murders, we really forced us to reckon with this past and what's going on, and it forced people to actually think about that this can't continue in this way, that this is not us. And so it was interesting to see that power really change and create a social movement in that way. And so, I definitely think that there's more optimism. I think with President Biden, for sure, with his selection of Dr. Vivek Murthy as the general surgeon, it brings hope that health equity will be prioritized with what he's already done in actually his less than his first 100 days in terms of that memo, the executive order that also called for expanded language access, as well as another one 2 days later that was focused on strengthening the Affordable Care Act and ensuring health insurance access for many. And then, what happened last year in terms of the social movement, it certainly has changed things at NIH and other places. We just saw, Beng and I were just looking at today at this new opportunity to be released by the NIH, a funding opportunity to examine, to understand, and reduce the experience of structural racism and discrimination on minority health and health disparities. It's unprecedented for us to really think about that and to call it out for what it is and to really be explicit in trying to make change. So I definitely think there is more optimism. And then the other thing about the COVID pandemic that's really what has been interesting and gratifying too at the same time is the renewed interest in public health careers, in thinking about prevention. So I think that we are hopefully moving in the right direction in terms of thinking about tackling social determinants, about reducing structural racism, and really thinking about putting prevention back into focus.
Dr. Guillermo Ramos?
So I agree with Benga and Chow. I guess if I were to be really honest, and so I'm just going to speak from sort of my personal perspective, I definitely think that never has there been a time when I felt that there's been more awareness that these long enduring trends have been sort of unmasked. And these big events, whether it be Black Lives Matter, certainly the coronavirus, I think they have shown in a really amplified way that inequities exist across a number of areas, and that those things have sort of rattled our sort of ability as a country to not in some ways face who we are. And some of what I think has been ubiquitous and what has really been sort of really ingrained in our society and the structures. And I don't think it's just about, I mean, Benga started us off with this. It's not just about individual people making decisions, vaccine hesitancy. It's really about systems and our institutions that are gatekeepers that operate in ways that facilitate some people doing well and others not doing so well. And I think that those things are sort of being questioned. I think the part that has been hard for me and where maybe I've been sort of struggling a bit as an individual, as a scholar, as a Latino person, is that I've also seen in this time sort of a real hesitancy for the kind of change that we need to really be manifested in our approach. And so again, just look at the term vaccine hesitancy. That movement to immediately make it about the populations that don't have access or that for whatever reason don't have the trust, and rightfully so, to be able to receive the vaccine. It's hard. I mean, story after story in the media shows that even in ethnic neighborhoods like Washington Heights or all over our city, who actually is having access and getting access to the vaccine versus who should be. There's a disconnect. And it's hard for me to understand that. I know that may be naive, but it's been surprising. It's been really surprising and eye-opening. What I will say is that I'm hopeful, and I don't want to end this evening without acknowledging the largest segment of the public health workforce, which is nurses. Estelle Osborne was a nurse. And I think it's important to acknowledge that there are 4 million nurses in the US, and that the vast majority of care, prevention, health promotion is provided by nurses. And I think it's important that that we think about opportunities to strengthen the entire public health workforce. It has been really apparent to me that there have been decades of sort of underfunding, of having a singular issue. I am fearful, as important as COVID is, that we're sort of losing ground on other issues. There have been disruptions in places where we've made a lot of progress. And so we reduced teen pregnancy, an area that's very close to my heart, by more than 50% in our country. But STIs are higher than ever. We've made tremendous progress in HIV and ending the epidemic. And yet we had significant gaps in terms of our PrEP and other services during coronavirus. When we think about deployments, a lot of our key leaders who are working in other areas of health have been deployed to coronavirus. There's got to be a better way, and there's got to be a sort of more integrated approach that sort of brings us forward in grappling sort of the truth about what we really need to do.
Thank you for that. All right, we have one final question before we start the Q&A portion of the session. So at this time, I would like to remind attendees to enter any questions that you might have using the Q&A button. I'm often asked by students, patients, providers, friends, and colleagues what they can do in their spaces to reduce health disparities. What would you say to them? Dr. Trent-Chevrin.
It's a tricky question. One of the things I've thought about is, given all that's happened in the last year, there is this fear of losing momentum and also sustaining commitment. And Vincent alluded to that, everyone was gung-ho towards the beginning, and it's starting to peter out a little. And so how do we ensure that health disparities, the need for systems change, the need to think about systemic racism and really tackle it in a way that is meaningful and genuine is really critical. And so just, efforts by all of us really, and including myself, is to think about how do I sustain my commitments? How do I, sustain genuine dialogue and do the work that I need to do to inform systems and policy change, and to be an advocate. One of the things, when you're trained as a researcher and, as an academic member, sometimes you forget that you also need to be an advocate. And I think that piece is going to be the most important piece in terms of really reducing disparities in a way that tackles it at the very heart of what's causing it.
Dr. Guillermo Ramos.
So that's a really tough question, but I guess, you know, as I've listened to folks that I work with in my community and also here at the university and across the country, I think I've been inspired by whoever the individual is, there's an interest in wanting to be part of the solution. And I think we need to capitalize on that. I think some concrete examples, if you think about schools of nursing, you know, applications are up. People want to become health professionals. They want to be part of, you know, addressing the inequity. I think that our institutions, and I guess I'll take a bit of an opportunity because I know that we have some leadership, both Dean Sullivan Marks and also Vice Provost McElwain, to say, you know, universities play an important role in advancing not only knowledge, but the betterment of our world, and that we need to be thinking about how does our research, our teaching, and our service make a difference in people's lives and inspire folks to come into our institution because they want to make a difference. And so what I would say to a student or to somebody that I encountered is become part of the solution. And I would ask that our institutions start thinking about how can we align what we do to better be responsive to real world problems.
Thank you, Dr. Ogadegbe.
Yeah, that's a tough question, but I'll tell you what I think. There's an allegory that I came across over the summer. It's by the Racial Equity Institute. The whole idea of the groundwater approach. So how we look at equity, health equity, for example. The idea being you've got to fix the system. We cannot fix people alone. So if I'm seeing patients in a primary care clinic, I run a hypertension clinic at Bellevue, some of my colleagues, and they have high blood pressure. So you take care of the high blood pressure. They're going to go home. When they get home, they can't afford the medications. Well, they're coming to Bellevue, you pay as you can, you pay as you earn. But, you know, they have two jobs. They cannot afford that lifestyle, diet, physical activity we want them to adopt. So what do? Well, we'll make it available to them. We'll make sure they go to a place where they can have that happen. Well, if you fix that, then the question becomes, where can they have that happen? In their zip codes where they live, they don't have such places. So the question then becomes, you know, what do you do? What you do is fix the system, make such things available regardless of race, income, or ethnicity, or religion, or whatever it is that is used as the next power. So I'm thinking that if I have to do something, talk to folks, I would tell them advocacy. I think Charles put it smartly well. It's something we often shy away from. As physicians, we do a lot. We just say, look, my job is to take care of the patient. 5 years ago, we were at the NIH, right? We're talking about hypertension in Blacks. What can we do to reduce this crazy burden of high blood pressure in Black folks? 52% Black women, hypertensive. So I said to the director of the NHLBI, happens to be an African-American, Gary Gibbon, I said, listen, stop racism. If we stop it, then my research will be done. NIH will not fund anything around racism. You fast forward today, as Charles just said, they're looking at that now. So that's what this pandemic has done, and the Black Lives Movement. That is, we're not beginning to appreciate that. So we need to talk more about that. We need to speak louder about that stuff. One final thing, what are we doing at the medical school? So the Institute for Excellence in Health Equity came exactly out of that movement. And the idea becomes, you know, we're going to look at our medical education. We're going to revamp how we'll, not just social determinants, because everybody teaches that. That's important. But what about the experiential practice of that? And that's the piece that we want to figure out, how to make sure that every student that comes across our institution, we have the ability to not only understand what those things mean, but to be able to practice it in a way where when they go out there, it's no longer surprising to them. So I think advocacy is everything, and wherever we are, we've got to figure out a way to advocate more for these issues. But on a policy level, not the individual, we should stop the blame game. People are diabetic, they have hypertension, they have whatever they have, not because of them. It's not their genes. It's the environment, and we've got to fix the policies to address those.
Thank you. We're going to begin the live Q&A. I have a question that reads, I'd appreciate your thoughts on how professional inequities have or are contributing to structural disparities and inequities in care delivery.
So I think maybe I'll start, Maya. So I think if we think about our sort of health professions and our public health workforce, I think across most of the disciplines, it doesn't really parallel our populations. And so I think there's a disconnect, between who it is that's sort of obtaining formal training, whether it be in a clinical discipline or in research or in public health or any of the ways in which we respond to the health needs of people in our country and beyond. I think we need to do a better job with that. I think when we think about what we learn once we enter in those specific disciplines, oftentimes there's some content that is related to diversity and inclusion, health disparities. I think we can do a better job. I think there can be more. I think there has to be sort of a real commitment at all levels of our institutions and our training programs to reflect the priorities and preferences and the knowledge and skills that are going to be needed to actually respond to the health needs. So for me, that would be a part of the solution.
I also think a big factor in terms of reducing inequities in the delivery of care is, both there's the language access, ensuring a bicultural workforce, but also really thinking through how do you increase diversity of our doctors, of our nurses, so that individuals, the patients who go in will feel very comfortable and feel like they're in a trusted space of being able to go to a provider that looks like them, that understands their social and cultural context. So really increasing diversity at that level, I think is a real key factor in improving better access and better quality of care.
Yeah, I think they've said it all.
All right, that was the only question we had for this evening. I want to thank our panelists for a great discussion. It has been my absolute honor to share the platform with you. Hopefully we can continue the conversation to move toward health equity. I would now like to introduce Dean Eileen Sullivan Marks, who will kick off the award ceremony. She has been the Dean at NYU Myers since 2012 and is currently serving as the president of the American Academy of Nursing. She is a distinguished nursing leader, educator, and clinician, known for research and innovative approaches in primary care, testing methods of payment for nurses, sustaining models of care using advanced practice nurses, and developing health policy in community-based settings.
There I am. Hello there, and welcome everyone. We have 120 more participants. It's really exciting to be here with you all. Next year we'll be in person again, and that speaks to the work that our panelists were discussing today. And we'll be in person again in a new world, and hopefully not only with hope, as the panelists described, but with renewed energy to continue to move forward with health equity and also addressing racism, which is a cause of poor health. And as Benga pointed out, I think that gets to the heart of the matter, and so we can all continue to work together. For those who just joined us, welcome to the 30th annual Estelle Osborne Legacy Celebration, where we celebrate the legacy of one of our own, former faculty member Estelle Massey Osborne, a pioneer who worked tirelessly to remove racial barriers and provide opportunities for Black nurses across the US. Our celebration today is a reflection of the values we promote at NYU Roy Myers College of Nursing. We strive for diversity, inclusivity, equity, and belonging throughout our school. Each day we affirm that diversity. We affirm that diversity enriches the educational experience, promotes a healthier society, and makes communities stronger. I'm proud to say that we have made great strides in bearing out those ideals as we have seen an increase in the diversity of our student population, as well as among those who are first in their families to go to college. There is still more work to do, and we continue to rise to the challenge of expanding academic opportunities for those who have been marginalized. We continue to recruit research and clinical faculty from diverse backgrounds because, as we know, learning with and from these leaders make our students better prepared to enter the world as it really is and to deliver high quality healthcare. We, for instance, have the Bernice Ferguson Professorship in Health Equity. Bernice Ferguson, a signature and exemplary African-American nurse who was a leader throughout the decades of my career, is an alum of NYU College of Nursing. NYU Myers is in the midst of a 5-year strategic plan that we call Thinking Big. BIG is an acronym for belonging, innovation, and global. As a college, we want to ensure we are building an inclusive environment for our future students, faculty, and staff. Today, in addition to honoring Estelle's legacy and our inclusion efforts, we are thrilled to recognize an alumna of the college who has strived to make differences in the nursing profession. This year's Estelle Osborne Recognition Award goes to Dr. Lisa M. Lewis, who is the Associate Dean for Equity and Inclusion and an Associate Professor of Nursing and Africana Studies at the University of Pennsylvania School of Nursing. Now, some of you may have known that I was at the University of Pennsylvania School of Nursing for a large part of my career and prior to coming to NYU. And the connection between NYU and Penn goes way back. In fact, several of you are alum of both institutions. But Lisa and I taught community health at Penn undergraduate program. And it was a privilege to be colleagues in community practice programs there. So it's a particular thrill for me to welcome her today and honor her. Before we continue our program, I'd like to acknowledge a terrible loss to the Osborne family this year. David Magruder, Estelle Osborne's great nephew, passed away on Christmas Day at the age of 49. Some of you remember meeting him at other ceremonies. He was a graduate of Howard University and pursued a career in law and performed community service his entire life, representing young people of color who were wrongly accused of crimes or in the wrong place at the wrong time. David comes from a legacy of Howard University alumni. Both of his parents are Howard University graduates, as is his wife, Dipel Shah. We at NYU Myers are proud to share this Howard University connection because we recently formed and announced just a few weeks ago a partnership with Howard University's College of Nursing and Allied Health Sciences. This partnership with Dean Gina Brown and myself and faculty is aimed at improving health equity, improving ways to think of workforce, learning from one another in mutuality, and focusing on research and education. David truly embodied this Osborne spirit, and he will be sorely missed by all of the lives he has touched. So we hope to honor his life with our connection to Howard and his great aunt's legacy here. Our heartfelt condolences go out to his wife, Dipel Shah, and the entire family. Now I'd like to tell you about the Estelle Osborne Scholarship Fund, which was established to award scholarships to high-achieving nursing students from underrepresented communities in nursing. To date, we have raised nearly half of the $250,000 goal that will establish an endowment so that the scholarship can be awarded in perpetuity. These funds have all been raised thanks to the generosity of the many donors of you out there whose contributions are vital to our efforts. I want to convey a very special thank you to alumna Dr. Catherine Alicia Georges, who included the fund in her estate plans. A planned gift is a wonderful way to make a generous gift through your estate and to assure that the Osborne legacy continues in perpetuity. Thank you for considering. Before we introduce our first speaker for the award ceremony, I'd like to start off by asking the audience to share with us the ways in which Estelle Osborne's legacy might have influenced your own careers. Please feel free to type them into the Q&A, and I will share them throughout the ceremony. To kick us off, I will be sharing remarks from her family. This particular memory is from Mark Magruder, who is Estelle Osborne's great-nephew. He says, "The lasting legacy of my great-aunt Estelle is education. Estelle helped raise my father, and she insisted he focus on education, and he pursued his engineering degree as an adult after his Army deployment. Now I am pursuing my master's in business administration in my 40s. The ongoing educational priority is a direct result of Aunt Estelle's guidance and leadership." Her great niece, Michelle Magruder Morgan, also has wonderful memories of Estelle Osborne. She says, "I have so many amazing memories of Aunt Estelle. I think that one of the most important attributes I learned from my dear Aunt Estelle that served me well in my career is to treat all persons with respect, no matter their situation in life. She was everyone's cheerleader, encouraging while also setting expectations when needed. I remember her humility regarding her numerous accomplishments. She was never one to toot her own horn. She also had a love of adventure and travel. My daughter Sophia and I found her on the passenger manifest of a ship from the 1940s traveling to the UK. She was indeed a trailblazer in her personal and professional life." Now it's my great pleasure to introduce a friend and colleague, Charlton Mcelwain. He's Vice Provost for Faculty Engagement and Development and Professor of Media, Culture, and Communication. The author of multiple books and scholarly articles, Dr. Mcelwain's recent work focuses on the intersections of race, digital media, and racial justice activism. Welcome, Charlton.
Thank you, Eileen. It's my honor and pleasure to join you and NYU's Rory Myers College of Nursing and all of you gathered together here this evening to celebrate, to honor, and reflect on the life and the work and the legacy of Estelle Osborne. I'm behind many of you. I'd never known Estelle Osborne prior to being invited to speak at this event. And so as much as I am thankful for this opportunity to say a few words, I am most thankful to have this occasion to come to know this extraordinary pioneer in nursing education, and in civil rights. I'm also always thankful to learn more about not only Black Americans and Black women specifically who have left such a legacy across so many domains, but to discover people like Estelle Osborne who were intimately connected to this institution, to NYU, and who have made this university better and stronger. It is clear to me that Estelle Osborne felt compelled to pursue her own professional passions, battling racism and segregation and all the things that kept her, for a time, from pursuing her dreams. But it was also clear to me that Estelle Osborne saw the value of building institutions that could scale her impact to new heights. One thing I noticed as I read some of the things that have been written about Estelle Osborne was a familiar pattern, a pattern that I think goes to the heart of her legacy and the legacy of NYU, the College of Nursing, and those who have come through it. And it's a simple pattern that we've seen played out even in the remarks that we've just heard. The pattern is simply this, that there first is something that has never been done before. People say, you can't do it. Or in the case of Osborne, you can't do it and you won't do it because of who you are. Then someone does that thing that they were told they cannot or would not do. And then once that person shows that it could be done, that it will be done, one after one, hundreds after hundreds, thousands after thousands follow, free to pursue their aspirations, knowing that someone has gone before them, broken down the barriers and blazed a path. This is Estelle Osborne's legacy, to not only to bequeath to new generations of Black women and men the capacity to aspire, but through her service in education, to open doors and build pathways for more generations to pursue their dreams. So again, welcome, as we all in the some way say a collective thank you to Estelle Osborne, to the Osborne family, the Myers College of Nursing, for continuing a legacy of equity, inclusion, and achievement. And I want to say a word of congratulations to this year's honoree. Thank you.
Thank you, Charlton. Wonderful words and very inspiring. And thank you for all the work you do here at NYU for the Rory Myers College of Nursing. You've been a great friend to us. Thank you. Many of us have shared ways in which Estelle Osborne's legacy might have influenced your own careers. And please remember to put some of those in the chat, and we'll read them. At this time, I would like to introduce Tanisha Canard. She is a baccalaureate student at NYU Myers and is one of the recipients of the Estelle Osborne Scholarship this year. Tanisha.
Good evening, everyone. My name is Tanisha Canard. I'm a second degree accelerated nursing student here at NYU. Of the 26 years I've been on this earth, I've spent a great majority of them dreaming about making a difference and leaving a legacy that would make generations after me proud. I've always been interested in nursing, but somehow ended up with a degree in psychology and a job as a social worker that didn't excite me. It wasn't until a year ago that I decided to take a leap. I applied to a school that I had always thought was way out of my league, into a program that both excited and terrified me. I prayed and I pleaded with God, and I got in. Eventually, doubt and fear began to creep in. I questioned my abilities and worried about the costs. So I prayed and I pleaded with God once again. Shortly after, I received an email that I was nominated for the Estelle Osborne Scholarship. And I prayed and I pleaded with God once more. And I received the news that I would be a scholarship recipient the day after. Receiving the scholarship not only calmed my worries and my fears, but it solidified my purpose and allowed me to recognize my potential. Your belief in me is invaluable. Your support is a blessing, and the scholarship is an answered prayer. Thank you.
That was lovely, Tanisha. One of the highlights of these ceremonies is always meeting the scholarship recipients. And it's just so sad, but that we can't be with you. And I know that so many of our alum who attend this ceremony and who are past recipients would be gathering around you right now and welcoming you to the Estelle Osborne family, and also to be doing photos with you. So just imagine all of that happening, because that's exactly what would be going on. Here's another, let me pick this up on my phone. Another comment from one of Estelle Osborne family members. Once I learned more about my Aunt Estelle, I realized we've been spiritually connected for some time. I attended her alma mater, Teachers College. I remember walking across the stage at graduation and reflecting on the legacy she created. I added a tribute to her in my announcement to acknowledge her many contributions and accomplishments, including being the first African American to receive a master's degree in nursing education, and to remind my loved ones and my fellow Black sisters and brothers, we stand on the shoulders of giants. That's from Renee C. Morgan, great niece. Thank you, Renee. At this time, it's my absolute pleasure to introduce our 2021 Estelle Osborne Recognition Award honoree, Dr. Lisa Lewis. Dr. Lisa M. Lewis is a master's alumna of NYU Myers. She is the inaugural Calvin Bland Fellow, Associate Professor, and Associate Dean for Equity and Inclusion at the University of Pennsylvania School of Nursing. During her 17-year academic career as a faculty member and administrator, she has built a track record of developing, growing, and sustaining mission-driven initiatives in cardiovascular health disparities research and in the areas of diversity, equity, and inclusion. Dr. Lewis's program of research focuses on reducing disparities in the behavioral management of hypertension for Blacks. Her most recent work is testing an innovative and interdisciplinary diversion program to reduce incarceration rates among Black men by addressing their health, education, and social needs. As an educator, Dr. Lewis's main focus has been to prepare nursing students who provide healthcare to the nation's ever increasing diverse populations. Welcome, Lisa.
Good evening, folks. I hope you can see me. Dean Sullivan Marks, thank you for the introduction. I can't remember that we did indeed teach together, probably now about 13 years ago. Folks, my computer died just as the panel started to speak, which just reinforces to me that they were an amazing and very hot panel, such that my laptop died. So I hope I'm coming across clear and that I am not choppy and that you can hear me. Tanisha, congratulations on your scholarship in honor of Estelle Osborne. No doubt she would have been very pleased that you did not let your doubts and fears overcome your desire to be a nurse. I am so honored to be receiving this award in honor of Estelle Massey Osborne. I'm not quite sure how my name came across to be nominated, but there are some awards that are particularly meaningful, and this one is it. I did not have the pleasure of knowing Estelle Osborne personally, and I can only imagine the type of courage she had to accomplish so much in her years here on this earth. This phenomenal woman, Estelle Massey Osborne, born just 36 years after slavery ended and living in a time of legalized discrimination, oppression, and state violence against Blacks. Some might argue that is still occurring. She accomplished so much, so many firsts. We know that she graduated from nursing school, but did you know that she graduated at a time when only 14 of the nation's 1,300 schools of nursing allowed Black people to apply? She lived during a time when the American Nursing Association, one of our nursing's largest professional organizations, did not accept Black nurses as members. An organization that was founded in 1896 and did not have its first Black president, Dr. Barbara Nichols, until 1978, and currently finds itself with its first Black male president, Dr. Ernest Grant. She paved the way for these two individuals. Estelle Massey Osborne was the first Black nurse to receive a master's degree in 1931 from Columbia University, I might add. And of course, we know that she became the first Black faculty member at NYU College of Nursing in 1946. And in between those time periods and well after, she worked tirelessly to remove discriminatory practices from nursing schools and to reduce health inequities in America. When you read about her on NYU's website, she's described as never tired or irritable, courteous, and perfect manners, even when she was not pleased. These are things that we often don't equate with courageous and fearless leaders. But folks, we don't have to know her personally to know that she was courageous. Our panelists have spoken so eloquently and expertly on COVID-19 related disparities. I wonder what Estelle Osborne might have to say about the death rates that for Blacks, Hispanics, and Native American populations that are 2 times that for white individuals, or the vast health disparities that continue to persist decades after they were identified. I think about the fact that life expectancy for Black men decreased by 3 years in 2020 from 71.3 to 68.3. Folks, 68 years is not old at all. Black women and Hispanic men and women also saw decreases in their life expectancy. It saddens me that she and so many others worked so tirelessly for the health and well-being of people of color. And while we have made some progress, thanks to her and members of the panel that you heard from earlier, it's not nearly enough. And it always brings me back to W.E.B. Du Bois's work, The Philadelphia Negro, the first document of the disproportionate poor health of Blacks as early as 1899. And it leads me to this quote in his book: "The most difficult social problem in the matter of Negro health is the peculiar attitude of the nation toward the well-being of the race. There have been few other cases in the history of civilized peoples where human suffering has been viewed with such peculiar indifference." This quote, folks, still rings true today. I know there's students in the audience and maybe others who read about me and my accomplishments. And my friends and family often tell me that I make it look easy. I and others who look like me have had to work against many of the systemic barriers and within and often against institutions that were not designed for us. And until such time that those barriers are dismantled, courage is what we have, the kind of courage that Estelle Osborne demonstrated. I can't tell you that I was born with this courage, but I certainly had role models that emulated it for me. Some of those role models paved the way for nurses like me and have long since gone on to be with the ancestors. The Estelle Osbornes, the Sojourner Truths, the Mary Jane Secoles, the Bernice Fergusons, just a few, so many others to name and on whose shoulders I stand. And I have mentors and allies, some of them coming from some very unexpected places, who were and are instrumental in my journey. The Benga Ogadegbis. Benga's been my mentor, and as he reminded me earlier this week, for almost 2 decades, a dear mentor and friend. The Girardin Jean-Louis, who with Benga are the co-PIs of a National Heart, Lung, and Blood Institute training program, PRIDE, which the focus of is to increase URM scientists. This program was pivotal in my courage, my self-efficacy, and my success as a scientist and an academic. The Tony Villaruels, Dean of the School of Nursing at Penn, my boss, and who saw something in me to appoint me one of her administrators. The Beth Winkelsteins, whom I work with in another role at the University of Pennsylvania. The Barbara Regals, the Calvin Blands, whose name I bear in my faculty title and allows me to do my most recent work to reduce incarceration rates among Black men. And Marge Wolf, who was one of my professors when I was there in the master's program at NYU and director of the nursing education program, and encouraged me to apply to PhD programs. I remember the very day, circa 2012, 2013, yes, this late, that I learned to claim my space in the world from Collins Arambua. And now I wake up every morning asking myself, how will I claim my space in the world today? I'm grateful for these and so many more. I'm surrounded by the love of family, both biological and families by choice, and friends, many who are on this call today. And lastly, and in no way least, I am grateful and give honor to my father, my first role model, though I am not sure I was able to acknowledge that he was my first role model until well into my adulthood. James Hubert Callender, born in 1942, an immigrant to the United States from Trinidad and Tobago, a man who was not able to finish high school, raised 2 of his 5 children on his own. I am one of them. Worked as a New York City taxi cab driver until his untimely death in 2009. Did such a really good job of feeding and clothing us that I did not know how poor we were. But he was determined that his children would have a better life than he did, and he was successful. I accept this award on behalf of him, my father, James Callender. I thank you, NYU, for awarding me this award. It is one of my most treasured awards. Thank you.
Lisa, that was just absolutely beautiful. And as all of the Estelle Osborne lectures are inspiring and meaningful to us as an NYU family. And if we were in person, I wouldn't even be speaking because there would be a standing ovation right now, as everyone would be thrilled to be with you and to hear your remarks. And you said, oh, I don't know how I got this nomination. Well, how could you not get this nomination? I mean, you are incredibly an NYU, a crystal, comes to mind as who you are. And we're proud to honor you today. And thank you so much for those remarks. And on behalf, officially, of the NYU Rory Myers College of Nursing, it's a pleasure for me to present to you today with the Estelle Osborne Recognition Award. You are the 56th recipient of this legacy award, and we're very proud. And I would be handing you, a beautiful, oh, you have it. Do you want to hold it up for everyone to see? That'd be great. Here it is. Beautiful. There it is. Thank you so much.
It's quite large. I don't know if my phone is capturing it all.
Oh, it's beautiful. No. And everyone knows how large it is who comes to these ceremonies. So that's be proud of it and enjoy it. And we're so thrilled. So thank you again. And I also want to thank our panelists and Dr. Maya Clark-Kataya for a beautiful work that she did on hosting the panel. Before we leave, I want to read one last response to how Estelle Osborne has influenced us from one of her family members. Aunt Estelle was a powerfully elegant woman. Though she exuded power, she was so accessible and down to earth. When she spoke to you, she was fully engaged and it made you feel important. Power should not overwhelm. From Carol Osborne Magruder, great niece. Thank you, Carol. That's a good thing to remember. Power should not overwhelm. I hope you've enjoyed this evening and have been inspired by the life and legacy of Estelle Osborne. Myers is committed to provide students the opportunity to achieve their degrees regardless of challenges. Endowing the Estelle Osborne Scholarship will mean that future generations of students will have continued access to a stellar NYU Myers education. I ask you to donate to the Estelle Osborne Scholarship Fund today. We will follow up with the giving link later this week, or you can go to our website at nursing.nyu.edu. Thank you for your support of our students in honor of Estelle Osborne. And thank you again to Vice Provost McElwain, to all of our panelists, and congratulations to Vince Galamo Ramos, who will be becoming the Dean of the Duke University School of Nursing in July. He's a great nursing colleague and represents so much that is important for us to be proud of. And I will look forward to having you as a colleague, Vince, as a Dean colleague. And congratulations again to this year's honoree, Lisa Lewis. Please stay safe and healthy, and soon we'll all be together. Thank you.